Hi guys, we're going to pick up where we left off with Chapter 11. Chapter 11 looks specifically at nutrition during pregnancy and infancy. I know some of you have children of your own, so probably for you some of this is going to be a review. But for others, hopefully you will learn something new about nutrition for both women and infants. Changes in the body during pregnancy. We're going to talk a lot about changes that take place and how those changes influence the health of a newborn baby. So, some terms that you're going to want to know, some different terms when referring to infants. Full term infants are those that are born between 37 and 42 weeks and weigh 3 to 4 kilograms, or 6.5 to 9 pounds. An infant is considered small for gestational age if they are born on time but failed to grow well in the uterus. A baby that is large for gestational age is heavier or larger than 8.8 pounds. An infant is considered to be low birth weight if they are under 5.5 pounds. Very low birth weight infants are under 3.3 pounds. And then we have premature or preterm babies are those that are delivered before 37 weeks of gestation. Maternal weight gain during pregnancy. During pregnancy, a woman's blood volume increases by 50%. The placenta develops to nourish the embryo or fetus, and the amount of body fat that a woman has increases to provide energy needed late in the pregnancy. A woman's uterus enlarges and muscles and ligaments relax to accommodate the growing fetus and allow for childbirth. Additionally, the breasts enlarge in preparation for lactation. We'll talk about lactation later in this chapter, but when we say lactation, we're referring to both milk production and secretion. So this figure is from your book. It's just showing the rate and composition of weight gain during pregnancy. So this is just kind of a average, typical example. In this case, the total weight gain is 25 to 35 pounds, and you can see there the breakdown of where that extra weight is distributed throughout the body. Maternal weight gain during pregnancy. Healthy, normal weight women should gain 11 to 16 kilograms or 25 to 35 pounds during pregnancy. The rate of weight gain is as important as the amount. Little weight gain is expected in the first 3 months or the first trimester, and typically in that time, weight gain is only 2 to 4 pounds. In the second and third trimesters, the recommended maternal weight gain is about 1 pound per week. Women who are underweight or overweight or obese at the time of conception should gain more or less weight, respectively, at a slow, steady rate. And of course, that's something that a doctor would be able to advise you more on. This graph is from your book, giving you an idea. The different colored lines correspond to different body types. And you'll see that first section of the line right before there's a little jump up, that's during the first trimester. So not a whole lot of weight gain there. Then after the first trimester, you notice the lines get steeper. The rate of weight gain increases, and for those individuals that start out already with a higher BMI, it's recommended that they gain less over the course of their pregnancy. And for those that start out as underweight, you'll see they're gaining more over the course of their pregnancy. So for somebody who's underweight during pregnancy, being underweight by 10% or more at the onset of pregnancy or gaining too little weight during pregnancy increases the risk of producing a low birth weight baby. Conversely, being overweight during pregnancy, that excess weight before conception or extra weight gained during pregnancy increases the mother's risks for high blood pressure, diabetes, a difficult delivery, need for cesarean section, and having a large for gestational age baby. Excessive prenatal weight gain increases the mother's long-term risk for obesity and may also increase the risk that the child will be overweight. Dieting during pregnancy is not advised. In the best case scenario, excess weight should be lost before pregnancy begins or after birth and weaning. Because dieting is discouraged during pregnancy, that's another reason why if a mother has excess weight at the time that she conceives, the recommendation is that she doesn't diet, but instead work to control her weight gain during the pregnancy. Physical activity during pregnancy. Being pregnant can interfere with balance and put additional stress on bones, joints, and muscles, increasing the risk of exercise-related injury. However, it can have a positive impact. Physical activity during pregnancy has been shown to improve digestion, prevent excess weight gain, low back pain, and constipation, reduce risk of diabetes and high blood pressure, and also speed recovery from childbirth. There are some guidelines to maximize the benefits of physical activity during pregnancy and minimize the risk of injury to mother and fetus. Women who are physically active before pregnancy can continue a program of about 30 minutes of carefully chosen moderate exercise per day. Those women who weren't active before becoming pregnant should slowly add low intensity, low impact activities. Because intense exercise can limit the delivery of oxygen and nutrients to the fetus, intense exercise should be limited. So you'll remember back to the last lecture when we talked about physical activity and how physical activity requires oxygen, right? Your body is pushing oxygenated blood to your extremities to allow yourself to move and exercise. So if you are exercising at a intense, rigorous rate, then your body is really pumping a lot of that oxygen out to your extremities and depriving the fetus of some of that oxygen. So that's why intense exercise should really be limited. However, more moderate or low intensity exercise can be good. This table is right from your text, table 11.1. I'm not going to go through it line for line, but it does give a good summary with a little bit more detail into the do's and don'ts of physical activity during pregnancy. Discomforts of pregnancy, some more good terms to study. The first, edema. You may have heard this word. Edema means the accumulation of fluid in tissues. Morning sickness is characterized by nausea and vomiting any time of day or night, usually in the first trimester. So despite the name morning sickness, it is not only in the morning, and I'm sure if you speak to anybody that's been pregnant, they can attest to that. To help combat morning sickness, it's recommended that pregnant women eat small, frequent, protein-rich meals. Pregnancy often can come with heartburn. In order to reduce your risk of heartburn, limiting high fatty foods, avoid heartburn-causing substances, eat small, frequent meals, and try to remain upright after eating. And last here, we have constipation and hemorrhoids. To prevent these, it's important to maintain a moderate level of physical activity and consume plenty of fluids and high fiber foods. So this diagram also comes right from your book, showing us what the female body looks like with a developing pregnancy. So you'll see the words all on the left there indicating to, the organs. Some of them are digestive organs, other just, other other organs like the heart, lungs. They all are in there, but you'll notice that with the growing pregnancy, it really shoves all of those organs to the side and kind of squishes them up against the wall of the body. And so with that, and kind of seeing how those organs rearrange themselves, it's certainly not surprising that a woman that's pregnant would experience heartburn, maybe acid reflux, and constipation. Complications of pregnancy. 4.25 million women give birth every year. About 12% of the babies born are premature. 8% have low or very low birth weights. Almost 7 out of 1,000 of those born alive die within their first year of life. And about 13 out of every 100,000 women die as a result of childbirth. Now, these last two statistics are things that you'll see a lot if you look at comparing infant mortality rates or maternal death rates. So these two statistics are often used when comparing health outcomes across the world. So they are pretty common numbers to see listed, and a pretty good measure of the healthcare system in both developed and underdeveloped nations. Hypertensive disorders of pregnancy. This includes a spectrum of conditions involving elevated blood pressure during pregnancy. About 6 to 8% of U.S. pregnant women experience high blood pressure. Hypertensive disorders cause over 12% of U.S. pregnancy-related maternal deaths. So that's pretty serious, and it's really important for doctors to, do regular blood pressure checks and really stay on top of, I thought I was going to sneeze, stay on top of high blood pressure in a woman that's pregnant or may become pregnant to make sure that they don't have any hypertensive concerns during the pregnancy. Hypertensive disorders of pregnancy are especially common in, pregnant women under the age of 18 and pregnant women over 35 years of age. Also low-income mothers and those with chronic hypertension or kidney disease. Some more definitions here. These are examples of some hypertensive disorders of pregnancy. The first, gestational hypertension, is an abnormal rise in blood pressure after the 20th week. Preeclampsia or toxemia is characterized by high blood pressure with edema and protein in the urine. It can lead to a reduced blood flow to the placenta, and it's pretty serious. It requires bed rest and careful medical monitoring, which and usually resolves itself after delivery. And the last one we have here is eclampsia, which obviously would follow preeclampsia if it's not treated properly. And it is really, really serious. It can cause life-threatening seizures, coma, and death. Next up, we have gestational diabetes. This is characterized by high blood glucose levels that develop in a pregnant woman. It's more common for women with obesity and family history of type 2 diabetes, and in African American, Hispanic Latino Americans, and Native Americans. A mother that has gestational diabetes has a 20 to 50% chance of developing diabetes in 5 to 10 years following the pregnancy. So even after the baby is born, If a mother had gestational diabetes during the pregnancy, it can continue to increase her risk for developing diabetes following the birth of the child. Additionally, the fetus is at risk for being large for gestational age and developing diabetes as a child. Nutritional needs during pregnancy. Energy needs. In the first trimester, energy needs do not need to be increased above non-pregnant levels. During the second trimester, energy needs increase by an additional 340 calories per day. And in the final third trimester, your energy needs increase an additional 452 calories per day. Macronutrient needs. For protein needs are increased by 25 grams, which equals about 1.1 grams per kilogram of body weight per day, and that is during the second and third trimesters. Carbohydrate needs increase by 45 grams, which is about 175 grams per day. Fiber increases by 3 grams of fiber per day. Fat needs include increased essential fatty acids and long-chain polyunsaturated fatty acids. However, the same distribution of calories from protein, carbohydrate, and fat is needed in a pregnant woman, same as it is in a woman that's not pregnant. Fluid and electrolyte needs. Water needs are increased to 3 liters per day during pregnancy, and this compares to the 2.7 liters a day that's required in non-pregnant women. And there's currently no evidence that requirements for electrolytes like potassium, sodium, and chloride are any different for a pregnant woman than a non-pregnant woman. Vitamin and mineral needs. For calcium, the RDA does not increase because calcium absorption doubles. So your body, for a pregnant woman, they don't require excess calcium because their body just changes to be better at absorbing calcium. So you just absorb more calcium from the food that you eat and don't necessarily need to be eating any more. Calcium is important for the development of teeth and bones, and can be found in dairy, calcium-rich vegetables, fortified foods, and supplements. Vitamin D, as we know, is important for the absorption of calcium and comes from fortified foods, supplements, and sunlight. However, like calcium, the RDA for vitamin D for a pregnant woman does not increase. Folate. The RDA for all women capable of becoming pregnant is 600 micrograms of dietary folate per day. Folate is essential for the synthesis of DNA and cell division, neural tube formation, which occurs 21 to 28 days after conception, and prevention of megaloblastic large cell anemia in the mother, premature births, and low birth weight. So you'll notice here, neural tube formation occurring 21 to 28 days after conception. That's really early in a pregnancy, and so this is part of the reason why it's so important that women of childbearing age, women that think they're going to be becoming pregnant, make sure they get enough folate, because once you find out that you're pregnant, at that point it might be too late to stop some of the negative effects on neural tube formation. Folate can be found in supplements, fortified products, dark leafy greens, legumes, and orange juice. Fortification and neural tube defects. If you look at some products, this one is pasta, there will be often, there's been a real increase in fortification of folic acid in recent years. This figure comes from your text. The graph on the bottom, you can see the rate of neural tube defects per 1,000 births. So in 1994, for every 1,000 births, there was about 1.6 babies born with neural tube defects. In 1998, some laws passed to make folic acid fortification mandatory in common foods, and you'll notice that from that point on, we've seen a drastic decline in the number of infants being born with neural tube defects. Vitamin and mineral needs. Vitamin B12, the RDA, is 2.6 micrograms per day. It's important for regeneration of active forms of folate and prevention of megaloblastic, which is large cell anemia. And vitamin B12 is found in animal products, fortified foods, and supplements. And the last slide here about vitamin and mineral needs. Iron, the RDA for pregnant women, is 27 milligrams per day, which is 50% higher than the needs for a woman that's not pregnant. Iron is important for the synthesis of iron-containing proteins, or hemoglobin, and for the prevention of iron deficiency anemia. Iron is found in red meat, leafy greens, fortified foods, and supplements. And finally, zinc. The RDA for zinc is 13 milligrams per day if a pregnant woman is 18 years old or younger, and the RDA is only 11 milligrams per day if a pregnant woman is 19 years of age or older. Zinc is important for the synthesis and function of DNA and RNA, and for the synthesis of proteins, prevention of fetal malformations, premature birth, and low birth weight. And red meat is typically a good source of zinc. Food cravings and aversions. Common cravings during pregnancy include ice cream, sweets, candy, fruit, and fish. Excuse me, you might have heard of pica. Pica is a craving for an ingestion of non-food substances with little or no nutrition. So for some pregnant women, they crave things like clay, laundry starch, ashes. I've seen dirt, all kinds of things. That obviously have no nutritional value, but for some reason, they really crave that. Common aversions during pregnancy include coffee, highly seasoned foods, and fried foods. There has been no proven cause for food cravings and aversions. Some assume that it's, a hormonal or physiological, psychological, or behavioral changes. But we certainly know that it does happen. So, for some reason it does. We don't really know why. But there's no denying that it does. Factors that increase the risks associated with pregnancy. Increased risks during pregnancy. The embryo and fetus are vulnerable to damage because cells are dividing rapidly, differentiating, and moving to form structures. Developmental errors can be caused by deficiencies or excesses in maternal diet and by harmful substances in the environment, diet, medications, or recreational drugs. A teratogen is an agent that causes a birth defect during a critical period in development. So a teratogen could be a harmful substance in the environment, could be medication, recreational drugs, anything that can cause a birth defect during the development of a fetus can be considered a teratogen. Excesses or deficiencies of weight or nutrients can affect hormone levels and fertility. During pregnancy, malnutrition can cause fetal problems, including growth retardation, low birth weight, birth defects, premature birth, spontaneous abortion, and stillbirth. Malnutrition can also affect a child's risk of developing chronic diseases such as heart disease, high blood pressure, stroke, high blood cholesterol, diabetes, obesity, and osteoporosis. Excuse me. The WIC program. The WIC program you might have heard of WIC, which is actually a shorthand way of saying Special Supplemental Nutrition Program for Women, Infants, and Children. It's much easier, obviously, to say WIC. WIC is a federally funded program and provides vouchers for the purchase of nutritious foods and referrals to health and other services for low-income women who are pregnant, postpartum, or breastfeeding, and for infants and children up to the age of 5 who are at risk of malnutrition. And for those of you who might not know, in Bangor, the WIC office is located at 103 Texas Avenue. I used to work in the same building as the WIC program. It's right off of the Rotary in front of GE by the airport, sort of on the UMA Bangor campus. And I know that even though that's where the Bangor office is, I know they do a lot of community outreach visits to other nearby towns. Maternal age and health status. For teenage pregnancy, the nutrient intake must meet their needs for growth and for the pregnancy. For teenagers, teenage mothers are growing themselves still, and during teenage years, it's a period of rapid growth for any teenager. And so when a teenager gets pregnant, they need to be aware of their own nutrient needs as their own body continues growing, in addition to the needs of their pregnancy. With teenage pregnancy comes an increased risk of hypertensive disorders of pregnancy and the risk of delivering preterm and low birth weight babies. For some teens that are pregnant, they may actually stop growing themselves because their body uses the nutrients that they consume for the growth of their pregnancy rather than for their own growth. This chart comes right from your book. It's showing the nutrient needs of pregnant teens. The red lines indicate, I keep thinking I'm going to sneeze. Sorry about that. The red line indicates the nutrient needs for non-pregnant teens, and then you'll notice the blue line is nutrient needs for pregnant teens. And for some, it's the same, for vitamin D, for vitamin E, vitamin K, calcium, it's going to be the same. But for most of these nutrients, their nutrient needs, double, sometimes triple with the addition of a pregnancy. So it becomes more important than ever for those individuals to pay attention to their nutrition. Pregnancy over the age of 35, more likely to have pre-existing conditions such as cardiovascular disease, kidney disorders, obesity, or diabetes, which can increase risks associated with pregnancy. Those who get pregnant over the age of 35 are more likely to develop gestational diabetes, hypertensive disorders of pregnancy, and other complications. They may also have low birth weight infants and chromosomal abnormalities. This risk especially increases for Down syndrome. And pregnancy over the age of 35 increases the risk of having twins and triplets with increased nutrient needs and preterm delivery. A woman who has had many miscarriages is more likely to have another. A woman with one child that has a birth defect has increased risk for defects in subsequent pregnancies. It certainly doesn't mean that it's certain, but the risk is there. A woman that's had fewer than 18 months between pregnancies has an increased risk of delivering a small for gestational age infant. And a woman that's had only 3 months between pregnancies has increased risk of a preterm infant and neonatal death. Toxic substances during pregnancy. Caffeine in excess is associated with increased risk of miscarriage or low birth weight. Pregnant women are recommended to limit their caffeine to under 200 milligrams of caffeine per day, which is the equivalent of 1 to 2 cups of coffee or 2 to 3 20-ounce soft drinks. Mercury in fish can cause developmental delays and brain damage. The recommendation for pregnant women is to consume 8 to 12 ounces of seafood a week from a variety of seafood types, avoiding fish that are high in mercury and limiting fish with lower amounts of mercury. It's important to focus on sources of lean protein, omega-3 fatty acids, and iodine. Food safety during pregnancy. You can see this is table 11.2 in your textbook. I'm not going to go through these line for line, but these are good recommendations to follow to make sure that you don't contract a foodborne illness during your pregnancy. During pregnancy, a woman's immune system is weakened, which increases the number and severity of infections. Listeria infections can result in miscarriage, premature delivery, stillbirth, or fetal infection. Listeria bacteria are commonly found in unpasteurized milk, soft cheeses, and uncooked hot dogs and lunch meats. Pregnant women are also at risk of contracting toxoplasmosis. Infected babies can develop vision and hearing loss, intellectual disability, and seizures. And toxoplasmosis is a result of contact with a parasite that can be found in cat feces, soil, and undercooked infected meat. Alcohol during pregnancy is a leading cause of preventable birth defects. Alcohol is considered a teratogen that specifically damages the developing nervous system of a child. It affects fetal growth and development because it reduces blood flow to the placenta and can impair maternal nutritional status. Infants that are exposed to alcohol while they're developing can develop fetal alcohol spectrum disorders, which is abbreviated FASD. And these are physical or behavioral conditions and functional or mental impairments linked to prenatal alcohol exposure, which includes fetal alcohol syndrome. Another risk, another teratogen, cigarette smoke, again, can damage the central nervous system of the developing fetus. It reduces the amount of oxygen and nutrients delivered to the fetus and can result in reduced birth weight, increased risk of stillbirth, preterm delivery, neurobehavioral problems, respiratory problems, and early infant death. Examples including sudden infant death syndrome, or SIDS. Even if a pregnant mother does not smoke, if she is around somebody who smokes, that secondhand smoke can still increase the risk that the woman has a low birth weight baby. And finally, drug use. It's important to discuss all medicines with a doctor. This includes prescription medications that you might have been prescribed. Just because they're safe for you doesn't mean that they're safe for pregnancy. There's been research that shows that marijuana and cocaine can enter the fetal blood. Cocaine reduces the delivery of oxygen and nutrients to the fetus, increasing the risk of miscarriage, fetal growth retardation, premature labor and delivery, low birth weight, and birth defects. Cocaine and other illegal drugs before birth can affect infant behavior following birth, leading to childhood learning and attention span issues. All right, lactation. Lactation is the synthesis of milk components. It's stimulated by the pituitary hormone prolactin. Then we have what's known as a letdown, which is a release of milk from milk-producing glands and the movement of that milk through the milk ducts to the nipple. It's stimulated by the pituitary hormone oxytocin, but can be inhibited by nervous tension, fatigue, or embarrassment. This is the anatomy of milk production. This comes right from your textbook. You'll see the milk producing gland That's known as the alveolus. Then we have the nipple, the duct that brings that milk towards the nipple, milk storage site, and also adipose tissue or fat tissue, right subcutaneously, right underneath the skin there. Nutrition during lactation. During the first 6 months, if a woman is breastfeeding, they will require an additional 330 calories per day. During the second 6 months of breastfeeding, they'll require an additional 400 calories per day. During that time, the RDA for protein is increased by 25 grams per day, and there are additional intakes recommended for carbohydrate, fiber, essential fatty acids, and several different vitamins and minerals. Because water makes up a large portion of a mother's milk, it's important for breastfeeding women to get an additional 1 liter of water per day, because it will result in a lot of water loss. And some energy and nutrients will be taken from maternal stores, so it's important that you replenish those with a nutritious diet. This table, again, comes right from your text, shows energy and macronutrient needs for lactating women. You'll notice the red bar is for non-pregnant women, the blue is for pregnant women, and the gray is for lactating women. So water and carbohydrate needs for lactating women are actually much higher than what they would be for a pregnant woman. For the other nutrients listed here, they're more or less the same, or maybe a little bit less when comparing the needs of lactating and pregnant women. And again, this one's right from your text too, showing micronutrients. It probably looks pretty small for you on your screen, but you can see just by looking straight down that the needs for pregnant and lactating women for many of the micronutrients listed here far exceeds the recommendation for non-pregnant women. Nutrition for infants. So the baby's been born, now what? Infant growth and development. Growth is the best indicator of adequate nutrition in an infant. A baby's birth weight should double by 4 months and triple by 1 year. Also, most infants increase their length by 50 inches. Infants are measured in length instead of height because obviously they can't stand yet, and it's much easier to measure the length of an infant laying down on a table than it is trying to get an infant to stand up and measure their height. So that's why length is used. Growth charts compare weight, length, or head circumference to averages in the general population of infants, ranking, including a ranking or percentile where the infant's growth falls in relation to population standards. So you might have heard, oh, your baby's in the 70th percentile. That means, that 50th percentile would be right average for babies born. 70th percentile means that they're a little bit larger on that growth curve. So that's all that the percentile means. Infant growth, not following the established growth curve or a sudden change in growth pattern could indicate overnutrition or undernutrition. Also, increased risk of obesity, diabetes, high blood pressure, harmful blood lipids, cardiovascular disease, even into adulthood. Failure to thrive is a term that doctors use. It can be caused by biological or psychosocial problems and can permanently affect growth, development, learning, behavior, and health. Infant nutrient needs. There are energy recommendations for 3 infant age groups. The first 0 to 3 months, then 4 to 6 months, and then 7 to 12 months. So energy recommendations, remember, those are calorie recommendations. However, nutrient recommendations are only divided into 2 age groups, 0 to 6 months and 7 to 12 months. For infants, they require an energy-dense diet. During the first 6 months, about 55% of the calories that an infant consumes should be fat. And then during the second 6 months, that decreases to about 40% of their calorie intake should be fat. And you'll notice these percentages are far higher than the 20 to 35% of energy from fat recommended for the average adult. And these graphs come right from your book. The top pie graph is showing the calorie distribution in human milk. So when a woman is breastfeeding, this is what the macronutrient profile looks like in that breast milk that's going on to her baby. And then on the bottom is the recommended calorie distribution for the adult diet. So you'll notice the proportion of calories from fat is much, much, much higher in an infant diet than in an adult diet. Excuse me. Infant water and iron needs. For water, an infant needs to consume more water per unit of body weight than adults do. This doesn't mean that an infant needs to have more water than an adult. It just means per unit of body weight, so per pound. Healthy infants who are exclusively breastfed do not require additional water. For iron, the AI from 0 to 6 months is 0.27 milligrams per day, and the RDA for an infant aged 7 to 12 months is 11 milligrams per day. Infants who are formula fed should be fed an iron fortified formula to make sure they're getting enough of this nutrient. More infant vitamin needs. Vitamin D. Breastfed infants should be supplemented with 400 IUs, which equals 10 micrograms per day, until the point where they're consuming about 1 liter or 4 cups of vitamin D fortified formula or milk per day. Formula-fed infants consuming less than 1 liter per day should receive a supplement of 10 micrograms per day as well. Vitamin K, all newborns should receive a 0.5 to 1.0 milligram injection of vitamin K at birth. Breastfeeding. Breastfeeding is recommended for newborns of healthy, well-nourished mothers. Sorry. U.S. health professionals recommend exclusively breastfeeding for the first 6 months, and breastfeeding with complementary foods for at least a year. Mothers can breastfeed as long after a year as is mutually desired, so mutually desired by both the infant and the mother, and lactation can continue as long as suckling is maintained. Some definitions here. Colostrum is produced by the breast for up to a week after delivery. It has beneficial effects on the GI tract of the infant. The nutrients it supplies meets the infant's needs until mature milk production begins. Colostrum contains more water, protein, immune factors, minerals, and vitamins, and less fat than mature milk. Then we have mature breast milk, which contains an appropriate balance of nutrients in easily digest forms. This table shows the composition of breast milk versus formula. It's table 11.3 in your textbook. There's a lot of debate about breast milk versus formula. Ultimately, it's whatever is best for the mother and the infant. Certainly the most important thing is that an infant is fed. There's plenty of reasons why a woman might not be able to breastfeed. Certainly breastfeeding is what's recommended, but a woman should never feel bad because she, for whatever reason, is unable to breastfeed her infant. So first and foremost, it's really just important that an infant is fed and receives the nutrition that they need. Benefits of breast milk. Formula can never exactly duplicate human milk consumption. In breast milk, there are cells, antibodies, and other substances passed from mother to child, providing immune protection. Growth factors and hormones promote maturation of the infant's gut and immune defenses and enhance digestion. Breastfeeding also contributes to physical, emotional, and financial advantages for the mother. When is formula better? Some substances can be passed to the baby in breast milk. These include tuberculosis bacterium, HIV, nicotine, some medications, alcohol, cocaine, and marijuana. So for a mother that uses any of those substances or has a condition that could be passed through breast milk, it's best to formula feed in that instance. Formula feeding also allows other family members to share in the responsibility, and there are special formulas that are available for preterm infants and those with genetic abnormalities. Alcohol and breastfeeding. Alcoholic mothers are counseled not to breastfeed. Occasional limited alcohol is probably not harmful. However, the alcohol intake should be timed to minimize the amount present in milk when the infant is fed. After consuming a single alcoholic drink, it's advised to wait at least 4 hours before breastfeeding. Alternatively, milk can be expressed before consuming the drink and then stored and fed to the infant later. Food allergies. These are common in infants due to their immature digestive tract that allows for the absorption of incompletely digested proteins, which then triggers an immune response. The risk of the risk of developing food allergies is greatly reduced after the age of 3, and many children who develop food allergies before the age of 3 eventually outgrow them. Allergies that appear after 3 years of age are more likely to remain. There are some things that you can do to reduce the risk of food allergies. The first is exclusive breastfeeding for the first 4 to 6 months. Then appropriate introduction of solid and semi-solid foods. First, iron-fortified infant rice cereal mixed with formula or breast milk. Then slowly introducing other grains, and finally adding wheat cereal. Each new food should be offered for a few days without the addition of any other new foods. And this is so that if a child does have an allergy or an issue with digestion, it'll be easy for you to tell what food the issue is with, so that you can make sure to reduce or eliminate that in the child's diet. Infant feeding. Solid and semi-solid foods can be gradually introduced starting at 4 to 6 months. Foods that can easily lodge in the throat should not be offered to infants or toddlers. Cow's milk should never be fed to infants. It doesn't provide the right combination of nutrients. However, whole cow's milk can be offered beginning at 1 year of age. At 2 years of age, cow's milk should be switched to a reduced fat or low fat milk, as the child's need for fat in the diet also decreases. And finally, infant feeding. Fruit juice can be fed from a cup when an infant is 9 to 10 months old. Not at bedtime though, or from bottles or covered cups that allow them to consume juice throughout the day. Having a constant or nearly constant drinking of fruit juice or other sugary beverages can really damage the development of young teeth in an infant. Added sugars should be offered in moderation, and honey should not be fed to children under 1 year old. Honey is one of those foods that isn't safe for children under 1 year of age. However, as they age, it's certainly fine for them to have. All right, well, that concludes chapter 11. I hope you learned something new, and for any parents in the class, probably heard some things that you have heard over and over before. So yeah, I hope you guys learned a lot. and I will see you on Thursday.